There we go. He's Dr. Raj Pillai joining us this morning, interventional cardiologist at the Indiana Regional Medical Center. We, of course, met you when you first came to Indiana.
That's correct.
And you were setting up the cath lab and the whole department, if you will. The
PCI program, we dealt with taking care of heart attacks, stents, and blockages in other parts of the circulation of the body. There was a department of cardiology, but just not the services that I provide, which are primarily interventional, which involves truly fixing blockages in the heart arteries in the setting of this hospital.
When you first arrived here in Indiana and began to institute those new procedures and give people in Indiana a chance to get procedures done here that they previously had to go to Pittsburgh or Johnstown for, just getting off the ground. Tell me about the progression of the department since you arrived.
The whole hospital has changed so much since I've come, because instituting a PCI program or doing cardiac stents and taking care of heart attacks really takes a hospital from one level to the next level. It really changes a lot about the hospital in terms of medications you have to carry, the personnel you need to know, the heart monitoring standards, the nursing standards, how the ICU works. Everything changes. Just so you know, I came here in July. It took me literally 4 months of me being here with multiple meetings and meeting with many different people before I could do the first stent procedure. Mm-hmm. So there were about 56 things that I needed done before I did my first case.
Yeah.
So that's why, and this is obviously they've never done it before, and I have done it before. I've started up a program before. So I knew what things I needed to have a successful program before I would do my first case. So I was here 4 months literally doing no cases till I would start my first case. So it was a process, and it's come out very, very well.
I remember when you first arrived, you were here with us on the air, and you talked about how that's really something you enjoy, is actually getting in on the ground floor and helping to set up departments such as the way that it is now.
Right. I mean, it is. I've already done it once, and it's probably the most satisfying thing I've done in my career, setting up a PCI program. It's not just the convenience that people have. Okay, we don't have to go somewhere else as long as you provide quality care, which we do. And it's more than that. In fact, since I've been here, we've taken care of almost 120 major heart attacks and about 300 minor heart attacks. And I've done, we've done about 1,200 heart catheterizations. And the point I'm trying to say is that at least 10 of those people would not have survived without a program right here. They were touch-and-go patients. They all lived. And also, the other vast majority of patients that we take care of with heart attacks, if they didn't do their procedure here or they didn't have the facility, the transfer delay itself causes such heart muscle damage that it alters their life, forever. You really can't get your heart function back.
Yeah.
And that's really the biggest difference this program impacts the community with. And it's the same thing in any other place where you start a program. A hospital this size should have had a PCI program, quite some time back, really. I would say at least 10 years back.
That time element that you speak of and the quality of care as well. Let's spend some time talking about what happens to the heart muscle itself if an event occurs and there's not somebody there who can help to reverse those difficulties right away.
Right. There's major and minor heart attacks. Major heart attacks is a completely shut artery, and every minute heart muscle damage is continuing to happen. And those patients, the quicker you treat them, the better it is for them. So much so that the government actually tracks the time from when the patient hits the door of our hospital to when the balloon is inflated in the patient's artery. It's called the door-to-balloon time. And it's tracked by national standards. It's tracked. And we perform extremely well. We perform above the 90th percentile for that.
Wow.
And that's one of the critical parts of it. Then there are minor heart attacks who don't have a completely blocked off artery, but they need the heart catheterization done as soon as possible, ideally within 24 hours. So service on the weekends also. We do heart catheterization 7 days a week, and we don't stop Saturdays or Sundays. If there's a minor heart attack, we follow the standard of care. And the other thing, too, is some of these minor heart attacks are so unstable that they also truly have to be taken care of like major heart attacks. So that's really where the time element comes. And quality is not just to do with the time. That's important. You also have to look at bleeding complications, stroke rates, and kidney damage from use of the dye. We perform extremely well in all of them, actually. We only had a single bleeding complication in 1,200 patients.
Wow.
And that is top 1% in the country. We've had 0 strokes, actually. Actually, no, we had one stroke that was not for me. It was a covering physician in about 1,200 patients.
Yeah.
That's less than 0.1%. And our renal kidney complications from the dye usage also have been extremely well, so much so that Corazon, who accredits cardiac cath labs, specifically commented positively on our on how we managed bad kidney disease during heart catheterizations.
It's pretty amazing what has been able to be accomplished here through your department. It's just
Absolutely.
It's something that didn't exist before. If we were to go back 30 or 40 years ago, when someone had a heart attack, and that automatically meant, okay, you're going to have bypass surgery, which is an open heart procedure, and it was so much different and so much riskier than the stent procedures that are there today in the balloon angioplasty.
Correct. The treatment of heart attack has evolved a lot. In fact, I was a fellow in India in cardiology before I came here. That was in 1997 through 2000. And back then, actually when I was a medical student before that, when patients had major heart attacks, we had very little to offer other than aspirin and heparin. And the death rate was about 10%. 10% of people with major heart attack died. And right now, the death rate is actually 2% of all the major heart attacks we take care of. And then came clot-busting medications, and we had them. They were good. They worked about 60% of the time to restore blood flow. In the 1990s in Michigan, Detroit, Michigan, they started a trial that led to balloon angioplasty being the standard of care for heart attacks. Since then, it has evolved where, the primary care for heart attacks or emergent catheterization and angioplasty, those patients do extremely well. That is the best way to take care of these patients.
I want to talk a little bit. We discussed so much prevention and how important it is, but I want to get to the other side, and that is after the surgical procedures have occurred and the follow-up care and the ability of people to get back to some semblance of normal life. That has to be a part of what you do too as well, doesn't it?
Oh, yeah, absolutely. Actually, most patients that we take care of are able to go back to normal life. The only people who really are not able to go back to normal life are people who sat around thinking that this is a reflux or thinking that this is indigestion, and then they come late and they have sustained fairly significant heart muscle damage. That can end up with heart functions that are half of normal, and then they end up with congestive heart failure or have a defibrillator placed that can change job prospects, such as you cannot drive a school bus, for example, if you have a defibrillator. You cannot get a commercial driver's license. There are certain heavy work that you cannot do if you have a defibrillator. And your life itself can change because you tend to have shortness of breath and admissions with heart failure, things like that. Except for those patients, the vast majority of people we take care of are able to return to normal life in a period of about 3 to 7 days.
Which is amazing.
Which is amazing. And sometimes some of the patients, I'd say approximately 15% of the catheterizations we do end up needing a heart bypass procedure. Those patients are able to also return to heart function, I would say more than 90% of the time in 6 to 8 weeks.
That's a fascinating, the science of it all.
Yes, it's very time dependent. And I think that's the key thing. You have to recognize it very early and treat it very early. And one of the things that we still have a challenge, and nationally is a challenge as well, is the time that the patient recognizes, okay, I need to call 911 or I need to get into the medical system. That time is the longest delay even today, is the recognition. And we try to educate people as much as possible, recognize the signs of a heart attack, so they come in as soon as possible.
With so many advances in medications, in procedures, and the way that your industry has progressed, it leads to the natural question, and you would be the guy to answer it. What's coming next?
In terms of heart attack care, very little has changed, I would say. Acute heart attack care, very little has changed since we started angioplasty and stenting from a perspective of revascularization or restoring blood flow. What has changed is we have devices that can support circulation that can be placed through the groin instead of large external heart pumps. So that's a huge change that we've had now. It's called Impella. It's a device that can support patients with massive heart attacks who would have otherwise died, where you can restore the heart's function, not exactly the heart function, it can restore the blood flow required for the body by a little tiny pump that's inserted through the groin. When we can do that right here in Indiana, we actually have the device on shelf. It's a very expensive catheter, but we do have that in patients who really need it. That's changed since stenting started. In terms of heart attack care, we have much better blood thinners that keep stents open a lot more often than what we used to have before. In terms of medications, not a lot has changed. A lot has been happening in the prevention area, But in terms of acute heart attack care, not a lot has changed in the last 10 years, except, what I said is, use of a catheter that can support the circulation when the heart is so badly damaged.
Do those technologies, the actual equipment that you work with, do they change much over the years?
I think since I've started doing this, which is since 2008, I think the stents have improved a great deal. The other things we use, balloons and wires, they haven't really not changed a whole lot. Stents have improved a great deal, and we also have some newer equipment to take care of chronically blocked 100% arteries. So there is constant improvement in technology. And the other big thing that has happened over the last 10 years is the emergence of use of the wrist artery for catheterization, which I think the United States still lags behind other nations quite by a large margin. When I started doing this, very few centers did through the wrist. I was fortunate to train in one of them. And in 2010, only 3% of the angioplasties were done through the wrist. And in 2016, if I remember correctly, that number was up to 17%. And that's still lagging a lot behind the rest of the world. Netherlands leads by more than 90%. And Japan is more than 50%. India is more than 50%. In the United States, we're still getting better at doing through the wrist, but it's not. In the United Kingdom, actually, the number of angioplasties done through the wrist is a quality measure that the government measures. There are controversies about that, but it is a quality measure for them. It is obviously safer with a lot more comfort to the patient and a lot less bleeding complications.
We're talking with Dr. Raj Pillai this morning in the Indiana Regional Medical Center. Interventional cardiology is a field that it's been around a while, but it is defined now as ever it has been. And I get a sense that the whole field just is a fascinating topic for you.
Yeah, there's a lot more to interventional cardiology than opening blockages in the heart arteries. In the state of Pennsylvania, we are limited at Indiana Regional. I'd say we cannot really fix heart valves. There are certain procedures we cannot do because we don't have open heart surgical backup in this hospital. So there are certain things that would require us to send patients to such a facility. The interventional cardiology is rapidly expanding in terms of valve care. Open heart surgery was standard for replacing valves. In the last year was the first year that more heart valves were implanted through the groin and the aortic valve narrowing condition of the aortic valve narrowing than open heart surgeries, which I think is remarkable. I mean, I could not have thought about this when I was a fellow, for example. And other heart valves also being treated in that way as well.
It's amazing. It is just a fascinating field for us on the outside to look at. From the inside, it just must be something else.
It is still fascinating on the inside as well.
Well, I want to thank you for coming in this morning to talk about heart health with us and the capabilities of the Indiana Regional Medical Center and what you and your staff are able to do. It's a really tremendous thing, and as you said, it's saving lives.
Thank you for having me. If I may add one thing, a lot of people are unaware of the fact that we take care of not only blockages in the heart arteries, we actually do a lot of work in blockages in the leg arteries that deals with non-healing ulcers and leg pain on walking. And that's one thing that I've noticed. I've been here and I've seen multiple patients who've had long history of non-healing ulcers who really never had their blockage looked at. And that's one of the areas I'm focusing on to improve recognition in the community, because we can provide appropriate care for those patients as well.
Oh, absolutely. Yeah, boy, that's another topic we could get into.
You're right.
I appreciate it. Thanks so much.
Well, thank you so much for having me.
He is Dr. Raj Pillai, the